So up to 50% of patients receiving chemotherapy for solid tumors.
Yeah.
Right? And an even higher percentage for those undergoing stem cell transplants. They experience this side effect that is so incredibly severe, it can actually force doctors to just completely halt their life-saving cancer treatment.
Yeah, and it's not hair loss. It's not nausea either.
Right.
It's this quietly devastating condition that, rarely gets talked about outside of oncology wards. We're talking about severe mucosal ulceration, which really stems from profound unmanaged dryness.
And today, we are focusing a massive stack of clinical sources on exactly this issue for you. We've got clinical guidelines from the NHS, comprehensive protocols from Macmillan Cancer Support, the latest breast cancer research, and even updated pediatric oncology networks.
Which is a lot of ground to cover, but it remains one of the most significant dose-limiting toxicities in modern oncology. You are essentially dealing with the destruction of the body's internal protective barriers.
Exactly. So our mission for this deep dive is to look at the science of how clinicians safely manage these acute mucosal ulcerations in patients who are actively undergoing chemotherapy.
It's such a vital topic.
Okay, let's unpack this, because if you really want to understand the treatments, you first have to understand the sheer scale, the biological burn happening inside the patient's body.
Right, because chemotherapy is, by its very design, a systemic weapon.
It goes everywhere.
Exactly. When it enters your bloodstream, it circulates with a primary directive to basically find cells that are replicating rapidly and just destroy them.
Which makes sense, given that cancer is essentially your own cells replicating completely out of control. The logic is sound.
The logic there is absolutely sound. But the catch is that the human body relies on several populations of perfectly healthy cells that also replicate at top speed.
Like hair follicles. That's the famous example everybody knows.
Yes, hair follicles.
Yeah.
But the most critical, rapidly dividing cells actually form the mucosal lining.
Right, which is that wet protective barrier that lines your mouth, your throat, your entire gastrointestinal tract, and the vaginal canal, too.
Yes. And if you look closely at that lining, you have this foundational layer called the base epithelium. Its entire job is to constantly push fresh new cells to the surface to replace the ones that get scraped away.
Just from normal things, like when you eat, drink, or just move.
Exactly. And because those basal cells are regenerating so quickly, the chemotherapy drugs mistake them for the enemy. So the chemo physically disrupts the renewal rate of that epithelium. The old cells slough off, but, well, no new cells are coming up to replace them.
Wow. And if you are a patient looking at your chemotherapy calendar, there's a very specific timeline for when this destruction peaks, right? It's known clinically as the NER window.
Yes, the NER.
Which essentially means the lowest point. For most chemotherapy regimens, somewhere between 7 to 14 days after the drugs are administered, your neutrophil count, which are the white blood cells that fight off infection, hits rock bottom.
And the crash of the mucosal lining perfectly mirrors that drop in white blood cells. As your immune system drops to its lowest ebb, the rapid turnover of the mucosa also fails.
So the tissue just thins out.
It thins out, it becomes profoundly dry, highly inflamed, and eventually it breaks open into ulcers. And clinicians measure this progression using the WHO oral toxicity scale.
Which is a pretty stark timeline of how quickly things deteriorate for the patient. Grade 1 is just the starting point, right?
Yeah, at grade 1, the patient experiences severe soreness and erythema.
That's clinical redness.
Exactly, but the skin is still technically intact. There are no open ulcers yet.
Okay, but by grade 2, the barrier breaks. The ulcers actually appear.
Yeah, and at this stage, the pain is highly localized and sharp, but the patient can still manage to force down solid food.
Barely, I imagine. And then grade 3 is where the clinical red flags really go up.
Definitely. You see extensive redness, widespread ulceration across the mouth and throat, and the pain is so intense, the patient simply cannot chew or swallow solid food anymore. They are entirely restricted to liquids.
Oh, man. And that leads directly to grade 4, where the inflammation and tissue breakdown are so severe that even swallowing water is agonizing. Alimentation, the basic biological process of taking in nourishment completely fails.
It completely fails.
Yeah.
These patients require intravenous nutrition and hydration just to survive the week.
But wait, if we know this cellular destruction happens to almost half of these patients, and we know exactly when it's coming, that 7 to 14-day NADIR window, it raises an obvious question. Why can't we just stop it before it starts?
Oh.
Think of our mucosal linings like a rapidly rebuilding highway, right? Your body is constantly laying down fresh asphalt, Chemotherapy is a bulldozer driving down the road, tearing up the fresh asphalt before it can even set.
That's a great way to picture it.
And this causes severe dryness, and inevitably you get massive potholes, which are the ulcers. So why can't the clinical team just park the bulldozer while the highway rebuilds?
Because parking the bulldozer means stopping the chemotherapy. You cannot turn off the drug's mechanism of action for the mucosal lining without also turning it off for the cancer cells.
Yeah.
You have to let the bulldozer drive.
Right, you have to treat the cancer.
Exactly. That said, clinicians don't just sit back and watch the highway get destroyed. They have a fascinating arsenal of frontline defenses.
They really do. And the very first one listed in the NHS Cornwall and Lanarkshire guidelines for certain drugs is shockingly simple. It's ice.
Yes.
I mean, I was reading through the prophylaxis protocols, expecting to find a list of highly complex pharmaceuticals, and right at the top, the clinical intervention is just to hand the patient an ice lolly.
Cryotherapy. It is honestly one of the most elegant clinical tools we have.
It's brilliant. The guidelines explicitly recommend having patients suck on crushed ice or ice lollies during the actual administration of specific chemotherapy drugs,
Yeah.
like 5-fluorouracil or high-dose melphalan.
And the mechanism here is pure physiology. When you apply ice to the inside of the mouth, the extreme cold triggers profound vasoconstriction.
So the blood vessels and capillaries in the mucosal tissue just physically shrink and tighten up.
Right. So while the heavy cytotoxic chemotherapy molecules are being pumped into the patient's bloodstream, restricting the blood flow to the mouth means those molecules physically cannot squeeze into the delicate tissues of the gums and cheeks in high concentrations.
Wow. So you are temporarily closing the off-ramp to that highway, and the bulldozer just bypasses the mouth entirely.
It's a brilliant mechanical workaround, but, it does have limitations. It only works for drugs with a very short half-life.
Meaning they are metabolized and leave the bloodstream quickly. You couldn't just have a patient suck on ice continuously for days.
Exactly. But for short, aggressive infusions, it is highly protective. Now, for more prolonged treatments or in cases like stem cell transplants where the chemotherapy conditioning is uniquely brutal, the guidelines do shift to advanced pharmaceuticals.
Right, and palifermin is a standout in the sources here. It's a synthetic keratinocyte growth factor. So instead of blocking the chemo, it essentially preloads the highway with extra asphalt.
That's exactly what it does. It binds to the receptors in the mucosal tissue and tells those basal cells to multiply rapidly before the chemo even hits.
So it artificially thickens the lining. That way, when the bulldozer comes through, there's still a protective barrier left behind.
Yeah. And alongside that biological approach, we are seeing the rise of photobiomodulation. You might see it referred to as low-level laser therapy, or LLLT.
Which sounds so sci-fi.
It does. It uses a small infrared probe placed inside the mouth or against the outside of the cheek.
And at a cellular level, infrared light penetrates the tissue and hits an enzyme in the mitochondria called cytochrome C oxidase. It basically supercharges the mitochondria to produce more ATP, which is cellular energy.
Right, and that massive burst of local energy speeds up cellular healing and severely blunts the inflammatory response before the ulcers can even form.
That is wild. But what's fascinating here is that medicine is just as much about aggressively pruning old treatments when the data shifts as it is about introducing lasers.
Oh, absolutely. The Children's Cancer and Leukemia Group recently updated their national guidelines to explicitly remove some older, highly common prophylactic treatments.
Yeah, nystatin and chlorhexidine mouthwashes are no longer recommended for preventing oral mucositis in children.
Because the clinical evidence showed they simply didn't prevent the ulcers. And in the case of chlorhexidine, the chemical makeup is far too harsh on an epithelium that is already being stripped raw.
Okay, so even with ice lollies, growth factors, and infrared lasers, the bulldozer still breaks through a lot of the time, right? The unmanaged dryness inevitably evolves into grade 3 or grade 4 ulcerations.
Unfortunately, yes. And when prevention fails, the clinical strategy has to instantly pivot to an escalation of care.
The goal shifts from protecting the tissue to keeping the patient nourished, hydrated, and crucially pain-free while the body repairs itself.
Exactly. And the sources outline a very specific stepped approach for this. If you are a patient at grade 1, so you're experiencing severe dryness and soreness, but your skin is still intact, the first line of defense is incredibly gentle. Clinicians recommend frequent saltwater rinses, just 1 teaspoon of salt in boiled, cooled water.
And the reason for the salt is osmosis. A saltwater solution is isotonic, meaning it has the same salt concentration as the cells in your body.
Right. If you swish with plain tap water or a harsh commercial mouthwash, it can actually draw moisture out of the already dehydrated cells or cause them to swell and burst.
But isotonic salt water cleanses the tissue without causing any cellular fluid shift. And then they pair that with artificial saliva sprays and moisturizing gels, right? Like a brand called Oraleve to constantly lubricate the mouth.
Yes. But if that patient progresses to grade 2, 3, or 4 where the ulcers break open and expose the nerve endings, salt water isn't enough. The clinical team escalates to heavy-duty interventions.
Bringing in specialized mouthwashes, like Cafazol, which I read can be used up to 10 times a day in severe cases, and a product called Gelclair.
Gelclair is really interesting. It's a bioadhesive oral gel. It operates entirely mechanically, almost like a liquid plaster or drywall spackle.
That's a great image. So the patient swishes it around, and the bioadhesive polymers physically bind to the mucosal tissue.
Exactly. It creates this thick protective shield over the raw nerve endings inside those ulcers. It locks out the air, the fluid, and the food that trigger that agonizing pain.
It buys the patient the mechanical protection they need to actually just eat a meal.
And they pair that mechanical shield with pharmacological pain management. A standard intervention is benzidamine 0.15%, often known by the brand name Deflam. It's an analgesic mouthwash that locally numbs the area.
But if the local numbing isn't enough, the guidelines allow for systemic painkillers like paracetamol. But, and this is huge, the sources contain a massive, bolded caution regarding other extremely common painkillers.
Yes, this is critical. Clinicians must strictly avoid giving patients antipyretic analgesics drugs that reduce a fever, like ibuprofen, if there is any risk that the patient is neutropenic.
And this is really a matter of life and death in acute oncology care. Because if you go back to that NEDIRA window we talked about earlier, the patient has no neutrophils.
Right. They have no white blood cells. Their immune system is functionally zero.
And when you have no immune defense, normal bacteria in your body can rapidly multiply and enter the bloodstream. The only warning sign your body can give you that a lethal systemic infection is taking hold is a fever.
Exactly. So if you give a patient a fever-reducing painkiller to help with their mouth ulcers, you might successfully relieve the mouth pain, but you simultaneously silence the body's only alarm bell.
You can completely mask a systemic infection, blinding the clinical team to a sepsis risk that could literally kill the patient within a matter of hours.
It just highlights how hypervigilant the care has to be. And the sources also list strict cautions for what the patient themselves should avoid. Alcohol-based mouthwashes are out, as the alcohol will instantly burn and dehydrate the raw tissue. Acidic or spicy foods are restricted.
And there's a very specific safety warning about petroleum-based lip balms, like Vaseline.
Yes.
Which applies to patients who are managing their dry, cracked lips, but might also be receiving oxygen therapy or head and neck radiotherapy. Petroleum jelly is highly flammable.
Very flammable.
So if you put it on a patient's face in an oxygen-enriched environment or under a radiation beam, you're creating a severe fire hazard. Patients have to switch to strictly water-based alternatives.
That's a vital safety point. But, we also have to remember that chemotherapy doesn't just stay in your head and neck. It circulates everywhere blood flows.
Right, which means any mucosal tissue in the body that relies on rapid cell turnover is directly in the crosshairs.
Which brings us to the vaginal tract.
Yes. The sources we have from the British Menopause Society and the American Urological Association point out that chemo-induced dryness profoundly affects the vaginal mucosa, leading to a condition called genitourinary syndrome of menopause, or GSM.
Because in a healthy system, estrogen is the hormone responsible for maintaining the vaginal mucosa. Estrogen tells the cells to stay thick and elastic, and it helps produce glycogen,
which feeds the healthy bacteria that keep the area lubricated and protected.
Right. But many chemotherapy regimens, particularly for breast and gynecological cancers, temporarily suppress the ovaries or even induce early permanent menopause.
So once that estrogen production shuts down, the vaginal tissues suffer the exact same fate as the tissues in the mouth. The epithelium thins out, it becomes dehydrated, inflexible, and highly susceptible to painful microtears and ulceration.
And this causes agonizing pain during intimacy, severe discomfort just from sitting or walking, and debilitating urinary symptoms. The clinical challenge here is immense.
I can imagine. You have a patient suffering from severe local estrogen deprivation. But if that patient has an estrogen-dependent breast cancer, their overarching cancer treatment is designed to eradicate estrogen from their entire body.
Exactly. Drugs like aromatase inhibitors work by blocking the enzyme that converts other hormones into estrogen. You are literally starving the breast cancer cells of the fuel they need to grow.
So the first-line protocol for the vaginal ulceration has to be strictly non-hormonal.
Hmm.
Clinicians prescribe high-quality vaginal moisturizers like Hyalofem or, yes, VM.
Which act exactly like the artificial saliva we mentioned for the mouth. They bind to the tissue and constantly release water to keep the cells hydrated.
And they pair this with specific, non-irritating lubricants for intimacy. But you might be wondering, if you just need moisture and lubrication, why can't you just grab a common over-the-counter brand like KY Jelly or Replens from the pharmacy?
Right, and the guidelines specifically warn against these for cancer patients. It actually comes down to the inactive ingredients.
Yeah. Many commercial lubricants use parabens as preservatives to give the product a long shelf life. But at a molecular level, parabens have a structure that is remarkably similar to estrogen.
Because of this shape, they possess what is known as weak estrogenic activity. They can physically slot into the estrogen receptors on cells, acting like a weak fertilizer.
And for a patient whose breast cancer is hormone receptor positive, introducing even weak, synthetic estrogen-like compounds into their system is a risk oncologists want to avoid entirely. So the products must be strictly paraben-free.
Exactly. But what happens if those non-hormonal paraben-free moisturizers simply aren't enough?
If the tissue is still tearing and the patient is still in severe pain.
Right. This is where the clinical guidance has made massive data-driven strides recently. If first-line non-hormonal options fail, clinicians move to a second-line treatment, entering into shared decision-making with the patient to prescribe ultra-low-dose vaginal estrogen.
Treatments like Vagifem tablets or Avestin cream,
Hmm.
or even vaginal DATA, which the local tissue converts into estrogen. But the immediate reaction most people have to this is just pure fear.
Naturally.
If their breast cancer feeds on estrogen, isn't giving them an estrogen cream incredibly dangerous?
Well, for a long time, the theoretical fear was exactly that any estrogen exposure would increase the risk of the cancer returning. But we now have massive, robust data sets that actually separate the theory from the biological reality of systemic versus local hormones.
Like the landmark study published in JAMA Oncology that we reviewed, it analyzed the health records of nearly 50,000 women across Wales and Scotland. It is a staggering amount of long-term data.
It really is.
And the results definitively show that women with breast cancer who used topical low-dose vaginal estrogen did not have an increased risk of dying from breast cancer compared to those who used no estrogen at all.
And if we connect this to the bigger picture, the biology behind why this is safe is fascinating. The dose in these localized treatments is ultra low.
Right.
When you apply it directly to the vaginal tissue, the basal cells absorb it and use it to do something called cornification. The cells basically fill up with a tough protein called keratin. They plump up and they form a thick, overlapping, waterproof shield.
Wow. And once that tough keratin shield is restored, the tissue actually stops absorbing the estrogen into the systemic bloodstream. It creates its own barrier.
Exactly. Blood tests confirm that the circulating systemic estrogen levels in these women remain safely at negligible postmenopausal levels.
So to go back to your analogy earlier, it fixes the local potholes on the highway without any of the repair materials spilling over into the broader interstate system.
That's exactly it. It allows clinicians to dramatically improve a woman's quality of life, her daily comfort, and her sexual health without compromising her oncological safety.
It's a perfect example of how targeted medicine can be. Whether you are a medical professional adjusting a care plan, a caregiver trying to help a loved one navigate side effects, or just someone looking to understand the complex reality of cancer treatment. The key takeaway here is the fierce balancing act that clinicians perform every single day.
They are managing a highly toxic cure. They have to let the drugs do their devastating work on the cancer while constantly mitigating the collateral damage.
They aren't just fighting a tumor, they are actively, rigorously protecting the patient's basic human functions, the ability to swallow a glass of water, the ability to eat a meal without agonizing pain, the ability to maintain physical intimacy with a partner. By meticulously managing the health of these mucosal linings, they are fighting to keep the person whole.
It represents the absolute core of supportive oncology. You have to treat the disease, but you must also protect the patient's humanity through the process.
So well said. Now, before we wrap up this deep dive, I want to leave you with a final lingering thought. We've talked about ice lollies shrinking capillaries, lasers supercharging mitochondria, and bioadhesive gels physically coating ulcers. But we also know that our mucosal linings, from our mouths to our GI tracts to the vaginal canal, are densely populated by our body's natural bacteria, our microbiome.
Right, our natural flora.
Millions of microbes call that specific highway home, and they actively communicate with our immune system to help maintain that mucosal barrier. This raises an incredible question that pushes just beyond the current clinical guidelines we've explored today. If those microbes are the natural caretakers of our mucosal tissue, could the future of preventing these severe chemotherapy-induced ulcerations lie not just in physical barriers or low-dose hormones, but in hacking the human microbiome itself? Could we one day engineer a probiotic rinse, like a specific bacterial strain that biologically shields those tissues, repelling the chemotherapy entirely and leaving the barrier perfectly intact? It's a fascinating frontier to ponder as we continue to evolve how we heal.